Hey. Welcome to episode 244. This episode is called Ethics in Action. And as I prepare for this episode, I've been thinking people want to live long and vibrant and healthy lives. But then there's so much uncertainty about life. We can get sick. Our loved ones can get sick, and that's part of things, part of the way life is. But even though it's a natural part of the way life is, there can be so much fear around it. Luckily, we have hospitals, doctors, nurses, and healthcare professionals who have seen things we might be dealing with many times before, but that all can still be scary. Luckily, I have two talented professionals to talk about all this with us. Introduce them formally, but first, this.
Today's guest, Amber Allen and Emily Leuthold.
Hey, welcome back. Amber Allen and Emily Leuthold hope both are nurses trained in clinical ethics who help patients, family, and healthcare professionals navigate the complex and sometimes agonizingly painful questions that often come in all shapes and sizes with healthcare settings. As I talked to Amber and Emily in preparation for this episode, it became abundantly clear that many decisions in medicine are highly emotional and complicated, with no ideal answer that 100% pleases everyone involved. Yikes. However, what can be created is a conversation where everyone feels heard and where ethical principles and frameworks are considered as an imperfect best decision is reached. I don't know about you, but when emotions run high, I want perfection. This conversation should be illuminating. If you've ever been curious about what it's like to work in this intensely challenging and rewarding field, had questions about morals versus medical ethics, wanted to know the difference between palliative care and hospice, or to learn about advanced care planning, this episode is for you. Please, without further ado, welcome Amber, Ellen, and Emily Leuthold. And let's hope I'm saying Emily's last name right, and I'm probably not. Hey, welcome.
Hi, Jason.
Thank you.
Thanks. Should we dive right in, or should we talk about the weather for like 10 minutes?
It's hot.
I mean, it is hot out.
I don't think there's anything else to say except that it is really hot.
Okay, everyone, whenever you're watching it, it's hot in South Dakota on June 20th.
It'll probably be raining by the
2025.
time that this airs.
What?
If there's a delay when it airs, it'll probably be rainy and cold by the time you air it.
Or it could be snowy. Who knows? Anyway, so what is ethics, and why should people outside, people even beyond people who work in hospitals, even give a second thought to ethics?
Well, I think it's important because it, in the hospital, we're seeing multiple different people, different cultures, different personalities, different faith backgrounds. Just each individual has their own set of morals and where they come from and the perspective they come from. And oftentimes, or sometimes, those don't jive with everybody else. And so I think ethics brings a lens where you can explore and ask questions and get to know that person better so that we're providing the care that they want to receive or in the way they want to receive it. And that it's based off of a framework that's equitable and person-centered, that maintains dignity, and that just really aligns with the quality or compassionate care that we want to be providing to each person.
So it sounds like ethics can really empower patients and their families to have a higher quality of experience as they navigate really tough issues. Is that fair to say, Amber?
Yeah, I would say so. I think that the word that's coming to mind right now is advocacy. And I think it's not only empowering for patients to know that they have a voice and have the ability to speak up for what they need in their care and what's important to them and what their values are. But I think it's also empowering to staff to hear that it's okay if a patient has different values or different preferences for care than what is our standard, because it allows them that freedom to know that it's okay. They don't need to carry that baggage with them. They don't need to feel like they didn't do a good job. They did their very best and provided the care that that patient wanted, needed, and was the most right for that patient. So I think it goes both ways.
So our role oftentimes involves coming in where there's these potential conflicts, or whether it's a conflict between individuals or just a conflict between values, whether it's, how do we support this patient's autonomy to make their own decisions, but also balance doing what we know is medically best for the patient or avoiding harm toward that patient, because sometimes those things aren't the same. And so we can come in and utilize the different ethical principles and different frameworks to have kind of a systemic process or systematic, I should say, to go through that issue and come to not usually a right or wrong answer. Sometimes there's a wrong answer, but there's often several right answers, but really trying to get to the outcome that is the least bad or the best or better. And so that's what we try and partner with both healthcare team and patients or families to achieve.
But we are still here. Mm-hmm. I don't know if you can hear us.
I don't either.
What? Can you hear me? Can you hear me?
You're back.
Wow, what? I'm not sure what happened.
Me neither.
You couldn't hear me for a sec?
Correct.
Huh. Well, that's interesting.
I break tech, actually. I'm pretty good at crashing things. So we can blame it on me. I didn't push any buttons, but
I just kept talking.
Huh, so this is a perfect example. Like we plan for our lives to go perfectly, but then tech issues, medical issues, stuff comes up. How do you help patients and families get move through that frustration that things are not going perfectly?
I think that's a really good question. You're right. Nothing ever goes according to plan. So we can kind of have some backup plans. And I try really hard to remember that, and we all have good days and bad days, but my patient is no matter what I have going on, my patient is arguably probably having a worse day than I am because they are hospitalized. And so they're probably not at their best. They're probably in a state of heightened anxiety, stress, frustration, and the things that happen, whether, through no fault of anyone, sometimes things just happen. Complications come up. The body doesn't do what we want it to do sometimes. Medication reactions. They're probably more sensitive to that. And I try to keep that at the forefront of my mind. And I try to just be supportive and hold the space and allow them to have their frustration, experience their emotions, whatever they are. Sometimes it's denial, sometimes it's anger, sometimes it's
grief. It's that grief cycle. And usually acutely in the hospital is not when we're seeing the acceptance of that.
No.
Sometimes we do. And that's always a privilege to be a part of too. But oftentimes we're with people, especially in the ethics world, where you're getting those more complex
anger
cases,
and denial.
We're in it with people during some really difficult and vulnerable times. So, yeah.
It sounds like such challenging work. How do you both stay excited about your profession and stay excited about going to work day after day?
Here's the secret. We are surrounded and part of an amazing team of humans, and we lift each other up when we have bad days, and we all recognize that some days we have bad days, and we dance in the elevators when nobody's looking except the security cameras. We embrace our silly mistakes or the funny things that happen in life, and we are just there for each other to help get through those difficult times. Something that affects me deeply or triggers something in me might not even be a blip on Emily's radar. And so that's why we're a team. And we work through these things together. And if I have to step back because it's, hitting me in a place where I'm now a little maybe too emotionally connected, my team, Emily or Gretchen or Abby, are right there to step in and help take the lead on that, and vice versa.
Mm-hmm. I think we can talk through things together, and definitely are a close-knit group where we can agree on a lot of things, but we can also have those conversations where sometimes our perspectives don't align, and we really learn from each other, learn how to think about things from a different viewpoint or a different lens.
And just like with our patients, sometimes we're not always extremely happy with the answer or solution either. There are parts of the system, the healthcare system, that we can't control, and we can't fix, and we just have to accept and work through some of that stuff. And when we get to those where we, as a ethicist team, are, slightly different, we play the devil's advocate. We work through it from the opposite point of view and talk through it and accept that they're both reasonable options, or they're both something that makes sense from that person's vantage point. So how do we move forward? Acknowledging that they're both wrong answers, but they're also both right answers at the same time.
Right. And I think I rest easier at night knowing that we were involved in this difficult case and were able to go through it with those frameworks and using the appropriate steps to get to some sort of resolution. Whether that resolution feels good or not, it doesn't always. But if I know that we got there the right way, that we asked the right questions, that we heard the right voices, that we involved the right people, and that we came to that best possible that we could do, then I know that we've done our role. And I can also then feel that we, as our healthcare team, have given that patient or that family the best that we can give. And sometimes, as you've coined, it's an imperfect best. And we can be imperfect from the side of the healthcare team, and patients and families can be imperfect. And it's kind of giving grace for ourselves, and not expecting perfection from ourselves, and knowing that, like, we're not going to just come in and just solve everything and make this good, but we can maybe make it better. So giving ourselves that grace, giving our patients that grace, meeting them where they're at, is kind of how we work through it and process, and how we're able to go home at night and leave the bad day behind, or the good day behind.
I think there's a lot of trust in our team too, and I think that's really important to highlight. When you work in a big organization, sometimes trust is a really hard thing to come by. And I think that's one thing that our team does very well. And I just am so proud of that. And I think that even in a leadership role, have the ability and the trust in my team that I can say and be vulnerable and say, I'm having a hard time with this right now. I need some support, and not feel like they are going to say, well, you suck at your job, or go tell someone that I'm not able to function in the lead role. Knowing that we all have those moments where we struggle with these really hard things, and that's okay.
You both of you keep mentioning team, and the goodness of team, and the goodness of conversation and debating, and you using ethical principles, and weighing options, and engaging in a methodical process over these really tough things. When a patient is sick, and they come in with their family, sometimes I imagine they can feel so bereft of a team, all alone, like they're the only one experiencing illness, and that can just be very terrifying. What would you both say that would help inspire people coming into healthcare settings to really rely on the team that surrounds them?
I think that, so I take that two ways, and I might let Emily speak to the patient perspective of that, and what she would tell to the patient to help inspire trust in the team. But I would almost start with how we train our teams and how we train our teams to put the patient first. When we think about a patient in a hospital bed that's admitted to the hospital inpatient, I said already they're probably almost certainly having a worse day than I am, but there's an incredible loss of control. Almost nothing about their hospitalization is something that they have explicit control over. They have to eat our hospital food. They probably have a hospital diet ordered. Maybe it excludes their favorite food or their caffeinated beverage that they need to get going in the morning. They have to get up and walk when our aides are ready to help them walk. They have to go to bed at whatever time, but then we wake them up to check their vitals. They have to eat their meals, between these hours. These are the times that we come give you your morning meds. It doesn't matter if maybe you're a night shift. I worked nights for a lot of years. Maybe I'm a night shift nurse and I'm used to taking my morning meds at 6 p.m. When I'm in the hospital, it's on the hospital schedule. And so I train and I encourage our teams to think about that loss of control. And when patients get mad or they're doing things that we feel are unreasonable, or they're, especially like if they're refusing things that we want them to do, it almost always is coming from like a place of like a control or we need to know why. Maybe they're trying to keep their home business going and they have a scheduled work call, so they really don't want to be interrupted and go for a walk during these 30 minutes. It's all sorts of things. And if we can train our teams to ask the why and find the curious questions and to understand where the patient is at, then our teams perform at a level that inspires trust, inspires our patients to believe that we're working and partnering with them for the best outcomes.
And I think things that we can do to work with those patients, I think number one, it comes back to remembering that people are human, that you're dealing with a person. It's not just the appendectomy patient in bed 2 or the stomach flu in bed 3 or whatever it would be. These are real people with lives outside of the hospital, and we only see this tiny part of who they are. So I think asking those questions, just treating people, saying good morning, asking about who they are as a person, acknowledging or validating whatever those fears or anxieties that they have, worries about being in the hospital, or maybe it's anger about that loss of control. So validating those things, building trust. So being clear in our communication, being transparent about what's going on, having good communication, making sure that they're empowered to ask questions, but then also getting answers to those questions that once we answer, we're checking with them, does that truly answer your question? I can provide an answer that somebody is still left either with more questions or wondering what the heck I just said. So I think using clear language, being transparent and open and honest, and really trying to provide empathy and that space for support is helpful, and trying to just advocate and empower them that their voice is important and that we want to include that in their care.
So for us, occasionally the screen is freezing, and again, it's just like we've planned this for weeks, and I didn't anticipate the screen freezing, but occasionally it is. Luckily, we can still hear each other, and it moves forward. Asking curious questions, and then Emily, you were really talking about making sure a patient understands what you're saying, you're telling them. And that brings up a great point. Like sometimes I know as a patient, I come from a healthcare family, in healthcare, but I know even for me, sometimes when I go into the doctor, it's nothing the doctor does, but I can almost feel I lose my voice because there's so many complex things going on. And and it's easy to feel like as a patient like I, like a person has to say yes to everything. How how can a patient maintain the voice and the agency in these really tough situations?
I love it when patients bring a friend or family member with them, because a lot of times healthcare has its own language. Actually, I think depending on your specialty, there's probably about 15 different languages, because I understand some of a lot of them, but there's a couple specialties out there that I don't understand a word. Neurology, I'm talking to you. So bring a friend, and that way you can listen and your friend can take notes. And if there is a question,
Do you advise friends to take notes like on a piece of paper?
Absolutely. Absolutely. And to pause the conversation. Hey, doc, you said a really big fancy word for something that has to do with the brain, I think, because you're a neurologist. Can you tell me what that word means? Our doctors are just so dang smart that sometimes they forget that, the rest of us don't speak that same language. And so bring in a friend. There's certainly almost never any reason that you can't say, I need overnight to think through this. And then you can come back to them with other questions as you find it.
So as a patient, we don't have to say yes right away.
No, you don't have to say yes at all.
So are there ever circumstances when a patient may not have freedom to say no? Or
I think that I never talk in absolutes, because as soon as I say something is an absolute, then life throws me a curveball, slaps me upside the head, and shows me that it's not. I think there's absolutely certain situations. One that comes to mind just recently, with May being like Suicide Mental Health Awareness Month, recently, a patient who's having suicidal ideation, they may not have the ability to say, no, I don't want to be admitted to the hospital. If they're having active suicidal thoughts, so there are always exceptions to the rule. But the general rule is that patients that have decision-making capacity do get to help direct those medical decisions and choose yes or no on the medical interventions that are offered. That doesn't mean that they can ask for things that aren't appropriate for their type of care. Our physician is the person who determines what are the medically appropriate options. You can choose A, B, or C. You can't choose D because that's not indicated for your type of condition. But generally speaking, the patient retains that autonomy to make that decision based on the available options.
how is it determined if a patient has decision-making capacity?
That's a good question. So in South Dakota, that's an attending physician that makes that determination, and it's a clinical judgment, and it's really based on 4 components. So We want to be able to see that you're understanding what the condition is, what's going on, why you're in the hospital, what the options are, what the risks and benefits or alternate options are. We want to see that you're appreciating those things. So you can understand it like you understand a textbook, but are you applying it to yourself? Are you able to appreciate your role within this and how it will impact you? We want you to be able to communicate a decision. That doesn't have to be verbal communication. Sometimes people are able to communicate that non-verbally, writing as well. And then a rationale. Ideally, we're able to understand the why behind your decision.
And that rationale seems to be congruent with your personal healthcare beliefs,
values, preferences,
and your goal of care. You can't tell me that the sky is green because the sky is green when you can objectively look at it and not. There's no reason behind that. You can't tell me I do not want to have a life-saving surgery today because I'm playing bridge this afternoon.
Well, maybe you really like bridge.
Yeah. And I think it's also important to just kind of note that decision-making capacity is decision specific as well. And it can wax and wane. So they can have it in the mornings and maybe not in the afternoons. Sometimes it just depends on their condition. As they get better, they get worse. An example would be a patient might not have the ability to understand the risks and benefits of a complex surgery, but they do understand and know who they trust to help them make that decision. My best friend is Emily, and she has known me for 50 years, and she knows what's important to me. And I know that I'm not quite thinking exactly right now, but I trust her to help me make the decision that's the best for me. Mm-hmm. And so they can have capacity to decide some things, but maybe not everything.
And then in South Dakota, we also, if somebody is determined to not have that full decision-making capacity for a complex medical decision, that's where we would turn to your healthcare power of attorneys if you have advanced care planning documents completed, or there's a hierarchy by law that we would go and, we would look at, is there a spouse that can help make those decisions, adult children, parents, and it goes kind of down a line. So we do have some guidance if that person's not able to make their own decisions for who to turn to.
So Emily, thanks for mentioning that. What is advanced care planning, and why should a person who feels healthy care about it?
This one's me? Yeah. All right. She told me ahead of time that I get to take advanced care planning.
It's her passion.
It is an advanced directive is a set of instructions. It is a set of guidelines for how you as the patient, me, how I want to be treated if I'm not able to make my decisions. So in that document, I have the opportunity to name who should be my surrogate decision maker. For some people, that might be their spouse, which is what the law would default to. For other people, that might not be a spouse or the person that is in that hierarchy. I think of patients that have been part of like a domestic partnership. That domestic partner is not legally recognized as a spouse. So that surrogate decision maker hierarchy doesn't catch them in that most important role, even though they know the patient the best. They fall all the way to the bottom of the list as close friend. So that advanced directive gives you the opportunity to say who we should contact. If that person's not available, who else we should contact. And then it gives some scenarios to help elicit what your preferences would be. If your doctor says that you are in a coma or a permanently vegetative state, and are not likely to recover, would you want to continue artificial hydration and nutrition? Would you want to continue with a breathing machine? Would you want us to resuscitate you if your heart stops? And so it gives some of those, situations and scenarios where you can kind of explain what your values are, what's important to you, what you think quality of life equates to, and help us to understand how we should treat you if you're not able to make your decisions.
Do these advanced care directives, if someone makes one in the 20s, do they like have an expiration date?
They technically do not. We encourage people to update them pretty regularly. A couple of triggers, a death in the family, like your surrogate decision maker has an unfortunate incident and dies or becomes incapacitated themselves, that would be a key to do it. If you're married and you've become divorced, that's another key to do it. If you have a new healthcare diagnosis, you've just been diagnosed with a chronic or a life-limiting disease or disorder, that would be a great cue to start some of that thinking or planning. And then, maybe every decade to update it.
So I'm just thinking for myself, I have one, but it hasn't been updated for a long time.
Hey, I can help you with that.
Yeah, you should schedule with us.
Probably. It's my cue to update it. Thanks a lot. What? Since we're on the subject, these are challenging words. I find them challenging. What's the difference between hospice care and palliative care?
Yeah, I think that's really fitting with this because as I'm thinking about what Amber's saying with life limiting or life changing diagnoses, that makes me think of palliative care. And palliative care is it really palliative, that palliate stems from a Latin word pallium, which means to cloak. And so with palliative care, the goal is kind of cloaking that patient. So cloaking symptoms, so covering symptoms, any symptoms from a chronic disease, emotional.
What do you mean covering symptoms?
So treating symptoms. So if you're diagnosed with a chronic lung disease or a chronic heart disease that are maybe causing shortness of breath or some type of pain, or if you're experiencing nausea, dizziness, tiredness, maybe lack of appetite from a cancer diagnosis, any of those types of symptoms that can come along with chronic disease are things that the palliative team are experts with that type of pain management with chronic disease. And so covering those symptoms and palliating, cloaking those symptoms to help improve quality of life. So that team really comes alongside it's at any stage of a diagnosis, a chronic diagnosis in any stage. So that can be from pediatric to geriatric, and any, from first diagnosis to later stages of a diagnosis. And you can do palliative care at the same time that you're doing curative treatments. So you can
you can do both at the same time?
Yes. Yep. So palliative care goes alongside you. You can be doing all of those curative treatments, trying to do what you can to treat that disease and live longer, at the same time using the palliative team to help with any of that symptom management, but also to help facilitate and support those goals of care conversations and talking about the stages of that illness, what to expect, and what your preferences might be in those situations. So it's a really great support to have on your team. Eventually, that may turn into a hospice situation, and hospice is that care, that type of palliative care. So it is a type of palliative care because we're still focused on comfort and treating those symptoms, but we stop treating the disease. we're now just really focused on you and what you're feeling and making you feel good for the days that you have. And how can we make those days the best they can be? So that's usually done with a terminal diagnosis where they're expecting less than 6 months of life is where that hospice care comes in best and where it really supports the patient. It might not mean that you die within 6 months. That can continue on because none of us know when that will happen. But that hospice care is there at the end of life with that terminal diagnosis to provide that comfort-focused care.
It sounds it sounds much nicer in a way than fighting up to the end, trying all of these extreme treatments that have so little chance of making a difference.
I think that depends on the person and what's right for them and what their preferences and goals and definition is. You know, for a patient who has a life event such as a child's wedding or the birth of a grandchild, fighting for each and every single day might be the most important goal. Whereas for another patient, it might be more important to have, you know, clearer days with less symptoms, even if that means less days overall. And so it really depends on each patient and their individual circumstances. And I think that that's where the palliative care team, you know, really shines, is in their ability to elicit or discuss these goals for care while still focusing on, you know, treatment and hoping and curing a disease. It's about planning for the what ifs and the what next, you know, kind of determining ahead of time where those curbs and gutters are. You know, my life has quality if I can do A, B, and C. If I no longer know who I am or recognize my family members, perhaps to me that means I don't have any quality left. And that's when I need to just focus on symptom management and staying comfortable. And so it allows for the patient to kind of define those terms in their words and in context to their life and their values.
Along these issues, it occurs to me, not an original thought at all, but I just want to ask the question now, so that's my segue. Kind of weak, but what's the difference between morality and ethics?
So I think of
easy
it,
question, I'm sure, to answer.
for sure. I think of it as our morals being more of our personal moral code, our personal beliefs, and that's influenced by our culture, by our faith, by our parents and our upbringing or family, by society, and oftentimes those morals, they're personal, but you can also have morals that are somewhat consistent as a society. But then ethics is really the process of deliberation of why you're doing something, why you're taking an action, and taking the best action that you can. So justifying actions as right or wrong, or the gray area in between, maybe most right or least wrong. So it's taking those customs and practices that are based on your morals and applying frameworks and using those systematic frameworks to justify the actions.
So am I understanding right, the ethical frameworks don't change from person to person?
Right. I wouldn't say they do. The frameworks are similar, are the same. You're looking at the same principles, and there are multiple frameworks. So, given a certain situation, you may use one framework, whereas another situation, it may be more appropriate to look at it from a little bit of a different perspective. But the frameworks, I would say, are the same. You're just also needing to pick up on the nuances of that specific situation. So it's not that you're always going to end up with the same exact recommendations every time you do a consult because you're using the same framework, but you're using those same questions and that same thought process to come to the best recommendation or outcome that you can.
But I do think that there is some space where your personal morals and your personal beliefs do shape the answers that you find on the frameworks. And I think that that's why it's important to have that collaborative approach and that team-based approach, because no matter how much whether you like it or not, your personal experiences, your morals, your values, your beliefs, they shape how you interact and how you make decisions. And so my personal bias, everybody has bias. It's a fact. There's multiple different types of bias and different ways that it influences things, some in a positive way, some in a negative way. But my personal beliefs, values, goals, preferences do shape the decisions I make and the answers to the questions through these frameworks. And so when you have that collaborative approach, you have someone who can, say, hey, but are you thinking about it this way? You value this, but the patient values this. So where do we find the middle ground? So while the frameworks themselves don't change per se, the answers can and do depending on your personal beliefs and morals. I like to think that we're all good people and, morally appropriate and good and just, but sometimes your beliefs can and do get into the way of what the right answer is. And that's why this team-based approach is so beneficial.
So what happens if like a doctor has one view, a patient has one view, two family members have different views, and you both have a different view? How does that not just, I mean, in the world today, we see a lot of things just degenerating into a big argument. How do these different views, how do you help these different views just not devolve into a huge argument?
I think, first of all, we remember that we're in a difficult setting. So we're not going to see people at their best. We oftentimes see those conflicts because these emotions come out in these really stressful situations. And those stressful situations can trigger other past traumas, other behaviors, things like that. So, number one is just understanding and trying to see where that patient or family member or even physician is coming from and what they might be facing. And then I think coming back to, are there known patient preferences that we can go back to for the basics, the patient's voice, and what are the known medical recommendations and what is being offered. The other stuff is kind of in the periphery. Making sure that all of those voices are heard and giving an opportunity for all of those voices to be heard because people want to be heard. So we kind of blow up that balloon and ask those questions, get everybody's input, and then you have to bring it back down to get to that next step and to move forward. Sometimes that is needing different education. Maybe somebody's mad or misunderstanding something and we just need to explain it in a different way. Maybe it's getting another team on for support to walk through. Maybe palliative's going to talk through those options a little bit more. maybe it's getting a second opinion or a consult and getting more information from the medical team.
Sometimes it's simply just a little bit more time.
Right.
One of the things that we frequently seem to encounter is, we have these options on the table, but they might not actually be options on the table in a day or two. Human bodies have a way of declaring themselves of whether they're going to get better or not. And what feels very urgent and like, we need to make this decision to us, why can't they make this decision to a family member who's never been in this situation before? It's incredibly overwhelming. And so sometimes we just need a little bit of time for the family to, see if there's changes, if there's improvement, or, if their loved one is declining or there's complications. Sometimes it's time to pray, to talk with other trusted people that are in their lives. And so sometimes really time is just the answer to help work through it, because that will sometimes eliminate some of the options that we thought we had.
Right. Or, with ethics, we're also trained in different mediation strategies too. So if we're really not able to have more conversation and come to terms, we can have more of a formal discussion that's mediated by ethics to try and get toward a next step forward.
So there's a variety of approaches that can be employed.
Yep.
But eventually there's a mediation that can help. So as we wrap up, what would you say to people about employing self-care as a way to deal proactively with stressful situations?
I love self-care. This is an area that I have done a lot of work in personally. I, for fun, teach yoga, and I think that there's just different ways for everyone. I'm surprisingly introverted, and sometimes I actually just need to go away from people and just have a half an hour to myself with a book or, whatever. Sometimes I need, physical exertion or some deep breathing or some mindfulness. But really listening and cueing into my body. And I'll be honest, as a team, we see that too. I have been told, do you really need to be here today? You seem very, you're right. I actually don't. And I need to go take care of myself. But every person on my team has had that same moment where we have had to either say to someone, I don't think you're at your best. And I think if you took some time coming from a loving, best, happy place, like take a little time for yourself. It's okay.
Emily, what will you add to that?
I'm kind of the same way. I do like to process talking through things, but oftentimes it's just sitting down with a good book, being outside, working in a garden, playing with the kids, whatever it might be. I'm also on our fire department in our local community, so sometimes it's just going to the station and sorting through stuff or getting some stuff done there that just kind of puts me into a different world for a little bit. So, and it's fun to try and put out fires, not like real fires, but when we're training and stuff like that. We've got fun toys on the fire department.
The training fires, that does sound fun. The training fires. Yeah. So as we wrap up, I'm thinking about the concept of imperfect best, and what it means to me as I envision the best I want for my life and to contribute to the people around me. And I go for that, but mistakes, obstacles, any which thing often come up, and instead of using that as a reason to stop, I try to learn from that and be inspired by that and move forward. What does doing your imperfect best mean to each of you?
So to me, my imperfect best means that whatever and wherever I am today is where I am today. Some days I can give 100%. Some days I can give 50%. And as long as I'm doing my best that day, imperfect best gives me the ability to offer grace to myself for not finding perfection and the reminder not to let perfection get in the way of something good. Sometimes good is good, even if it's not quite perfect.
And this question is, I was thinking about it. I came across something that I had written back in 2018 when I was on our nursing ethics committee. I was a nurse in transplant at the time, not working full time in ethics or anything like that, but had just kind of started my interest and was taking a course from actually our now coworker Gretchen, called Embedded Ethics. And it's a series that she offers here for staff at the hospital to learn some of those foundations. And that day we were talking about our covenant with our patients and what covenant you would offer. And I think reading through what I wrote at that time, it really reminds me of your concept of imperfect best, and also speaks to how nursing and clinical ethics really combine, and why the nursing role benefits me, I think, as a clinical ethics. So I was just going to read that quick. It's really
first of all, before you read it, Amber, if you need to get to your meeting, you definitely can take
I want to hear this, but then I'll buzz off to my meeting.
Duty calls.
So Emily, before you read that, what do you mean by covenant with patients?
Our contract with our patients, our fidelity, our
patient pledge.
Yeah, kind of what I want to promise to myself as being a nurse, and what I want to promise to my patients, how I want to be. And so I wrote, I promise to be present. I promise to do my best to help you be your best. I promise to listen. I promise to advocate for you and be your voice when you need me to. I promise to go the extra step. I promise to communicate. I promise to keep myself educated and in the know with what you need to know. I promise to hear what is important to you. I promise to be honest. I promise to seek what is best for you, even if you don't like the answer. But I promise to explain why and how. I will work to benefit you. And I think those words that I had then are still very near and dear to my heart right now, for how I practice and how I want to be seen as a nurse and a clinical ethicist, and the things that I want to project toward other healthcare providers. So that was really good.
It is really good. And Emily, you win the award for the first time in 244 episodes. You're the first one who brought notes to this question. That's wonderful. Thank you. And thanks both of you for being on. Thanks for the amazing, challenging, invigorating work you do, and and we will. I really appreciate it. Thanks a lot.
Thanks for
And
having us.
Yes, it was a blast. Thank you.
have a good meeting, Amber.
We'll see.
And Emily, I'm going to end the show, but please stay on for a
Yep.
few minutes, okay?
Will do.
So everyone, thank you for tuning in, whether you're watching this live or watching it 20 years from now. I believe complex medical decisions will still be present. So thanks for considering the things that are challenging and doing what you can to prepare yourself as we all move forward in life with the opportunities life gives us and with the challenges life gives us. And most of all, thanks so much for being you. And leave comments if you want. Your comments inspire others, and we love comments. And tune in next week for another episode of Ugly Awesome Podcast. Have a good day.